Hi, I'm Dr. Lauren Doyle Strauss, and I'm a pediatric and adult headache specialist at Wake Forest Baptist Medical Center. And I'm excited to join you here to talk about pediatric migraine.
And I'm Dr. Jessica Gautreaux. I'm also a pediatric headache specialist. I'm located at Children's Hospital in New Orleans and Louisiana State University Health Sciences Center in New Orleans. And today we're going to cover just two parts of the broad topic of talking about pediatric migraine. We're going to try to focus today on helping you with diagnosis of the primary headache disorder, and then we'll move in a little bit into components of treatment of migraine disease in children and adolescents. And Dr. Strauss will start us off with the diagnostics portion.
Well, I'll first start off that it can be really challenging to diagnose migraine in children. Headaches definitely are common in children. We estimate about a third to a half of children will go on to have recurrent headaches. 2 to 6% will actually even go on to have a daily headache. So headaches are common in childhood. About 10% will go on and meet the criteria of migraine. There are a lot of things that make this more challenging. Children may have trouble explaining their symptoms, especially our younger children. Children definitely experience things differently than adults, and they may have visual or sensory symptoms, that we know can happen with aura, and they may actually think they're normal because that's all they remember and all they know, and they may not think that they're worrisome and may not report it to their parents. And, one of the myths that we often come across is that boys can't have migraine. They think only girls can have migraine. And so a boy experiencing pain may be missed. And so that's something that adds to the challenge of identifying this. And children may stop reporting their pain. We know that migraine often goes undiagnosed, not recognized and undertreated. And so, if they continue to have pain that's not being treated, they may stop reporting it and just start to adapt and avoiding activity and just go to sleep. And so they may not always be telling their family or their teachers or their school nurse when they're experiencing pain attacks. So it becomes harder to track over time. So I think the biggest key is really listening to the parents and involving the child in the conversation. And we have a classification through the ICD-3 looking at pediatric migraine, and I'll walk you through that. There are some nuances, and the big takeaways are that are the difference between the adult side is that we need to have a minimum duration of at least 2 hours versus on the adult side, it's 4 hours. And you want to kind of do a little bit extra questions there, not just how long is the pain, because children often go to sleep as an adaptive response. So you want to ask how long are they sleeping and include that portion in the time to make sure that you're over that 2 hours. And also they may be quick to treat. So you want to ask what's the longest it could be without treatment. And light and sound sensitivity, it can definitely be inferred from behavior, which means, you may ask some additional questions because kid might not go around and say, oh, I'm sensitive to light and sound and know exactly what you mean when you ask that. So ask things like, oh, during an attack, are they burying their head under a pillow? Are they asking everyone to turn off the TV or the music or complaining about their older brother who's loud in the room next door? Asking some additional questions to see if their behavior shows that they're bothered by that. And location, we know that one of the headache characteristics is unilateral. However, most kids have bilateral location, and so it's as they get older that unilateral location becomes more common. So generally, the criteria look very similar, but those are the specific areas to notice a difference in. And I also want to say is that it's really important to listen to what parents think are the most concerning symptoms. And it may not always be headache, and you want to listen to them and involve them in the conversation because you don't want to miss another cause for headache and miss something that may not be migraine. And there are a lot of potential red flags out there. Definitely if it's a recent onset, severe, maybe they've had a history of headache and then it became severe out of nowhere. Want to listen to that and not just assume that it is migraine just because they're a child. You want to listen, does the quality, does something change? Did it always respond to medicine and now it's not responding? Is the headache waking them up from sleep? So you want to know, if they say yes, did they go to bed with headache and then they woke up later with headache and still occurring? That's different than going to bed without a headache and out of nowhere waking up with a headache. Is it triggered by certain activities? You know, is this only happening during like gymnastics when they're doing a special maneuver and all of a sudden this happens? You know, is it induced by some exertion, exercise, Valsalva? Is there some relationship that some clue there that means that there could be something else going on? And in childhood, sometimes headache is the first symptom of another disorder. And so I always do a careful skin exam or ask parents to point out if there's any interesting birthmarks. So you don't want to miss a neurocutaneous syndrome that could be, you know, causing seizures or something else, and that you don't want to miss. And then in our young children, that just even being a young child altogether could be a red flag. And you know, I know it's challenging to take a history from a younger patient, but certainly involve them, ask them what their experience is. Sometimes we have to get really creative. We have to ask them, you know, can you draw what you're experiencing? You know, is this something that's easier with art, you know, what you see or where the pain is located? You can be hands-on. Sometimes I put my hand on a patient's head and I said, you know, the throbbing or the pounding, maybe they don't understand those words. Does it feel like a pulse? Does it feel like a heartbeat? So involve the patient, the parents, try to sort out what are the most bothering symptoms and try to be a detective through the process. It can be really challenging. And then keep reevaluating. You may have diagnosed someone with migraine, but when they come back for follow-up and they're worried and they said these medicines aren't working, that may be the time to reevaluate. Do I need lab work? Do I need to do an MRI or imaging? Do I need to keep pursuing another cause if they're not responding as expected?
Thanks, Dr. Strauss, for sharing that with us. I'm going to move into talking a little bit more about the management of migraine as a disease. And so I think many people in primary care, many practitioners in primary care recognize some of the tools that are out there to manage migraine. So they recognize that there's acute medications that can be very useful to relieve an individual pain attack. I think also many people are aware of things like preventive agents that are there to try to change the frequency of attacks or modify the disease in some way. But really, managing migraine is multifaceted. And it's very rare that you're going to have an individual patient where just one of the tools in the box is what you want to go to. You really typically are giving them a multifaceted treatment plan. And I think one of the parts of what we do that's really hard for people to conceptualize is this idea that people with migraine disease should be taught what things in their lifestyle, what things within their power can be done to try to modify the disease. And I think that's kind of a tricky subject because it's hard to understand the specifics. It's hard to understand why it works or why we do these things. So that's really what I want to spend most of my time on today. I'm not going to get as much into specific medication options that's there in some of our other materials, but I really want to focus on this kind of vague or tricky area of talking to people about what they can do to modify their disease. So, in the American Academy of Neurology guidelines for managing pediatric migraine, one of the items that has level B evidence is talking to patients about lifestyle modifications or what things in their lifestyle may impact this disease state. So, it's a recommendation, but then how do you do that? Or how do you do it where it's useful for patients? Because a lot of people will say they've tried changes in their lifestyle and it didn't work. So, that's what I want to kind of go through today. So I think the very most important part of leading into talking to someone about lifestyle modifications is first making sure that you did not miss what Dr. Strauss was talking about, which is making the diagnosis. So patients have to understand that you're confident that the cause of their headaches is the disease state of migraine and that this is a disease that likely will be with them through life. And then I think that helps them understand better why there are things about their daily life that might impact their disease. And they've heard this in other diseases. There's very few diseases that people live with throughout life where the solution is just one medication, typically things like heart disease, diabetes, lots of different things that we encounter that are with patients for that are longstanding are influenced by things other than just medications. So I think first helping them to conceptualize that idea that this is a disease state and this is your cause of your headaches is very important. Because if you launch into things like talking about drinking water and eating meals, they may think you're trying to say that's the cause of their headaches. And then people can get defensive and feel like you're saying they're causing their headaches. They may think that you're blaming some of their behaviors for their headaches. And then we also know that migraine disease carries a lot of stigma anyway as a disease state that we're trying to get over. And so you don't want to then add on to that by suggesting that people who have migraine cause their own headaches. So I think first make it clear that you understand the cause of the headaches is migraine. Make sure the patients understand that they have a disease. And then you can launch into there are things that we do day to day that might influence this disease state. I think it's also important when you talk to patients about lifestyle modifications that can impact their migraine disease, that they understand that that's not always the same thing as a trigger. So talking to someone about having good, healthy habits, for example, in regards to their sleep over time, doesn't mean that you're saying you got one good night of sleep, you're not going to get a migraine the next day. What you're really talking about is their patterns over time impacting this disease pattern, not necessarily each individual attack. And so you have to set appropriate expectations, because if you talk to someone about make sure you get good sleep and then they get a good night of sleep and have an attack, they may abandon that recommendation right away because they didn't understand that you were talking about this is a change in your habits, not an individual relation day to day. Another one that comes in is skipping meals. People will think, well, I ate breakfast that day and I still got a migraine that day. So this is not good advice. So you really have to talk to them about the influence of lifestyle on the disease state, that this is kind of long-standing habitual change that will in fact affect their disease over time. And then I think you can make progress there. So first the understanding, then the appropriate expectation. The next thing that's really important is I think that people who are being told that they can change their habits to impact their migraine disease really need to be given specifics. So it's not enough to tell someone get enough sleep, eat your meals correctly, or make big changes when maybe they were so skewed already that drinking more water, going from 1 bottle to 2 bottles, is an improvement to them, but they're still nowhere where they need it to be. So I think you have to outline specifically what the modifications are that you want to look at, and then you want to help them develop some specific goals that are individualized to them. So the typical things that we talk about are the SMART habits. And so that mnemonic is really useful because it stands for S for sleep, M for meals, and I add in hydration there. A is for activity recommendations, R is for relaxation, and then T is for trigger management. So when we talk about sleep, you want to make sure that pediatric patients are getting somewhere between 9 to 11 hours of sleep. And I think most people are aware when you're talking to teens and children about getting enough sleep. But the other two pieces that can be really important for migraine disease is that sleep quality is good. So you want to make sure they don't have sleep apnea, aren't having frequent nighttime wakenings that needs to be addressed. And then the second thing is talking to them about getting on a consistent sleep schedule. So it's very common to have a school schedule and a weekend schedule. So you want to try to help them avoid that and teach them that not only do they need to get enough sleep every night, skewing that schedule night to night from weekends to weeknights is not good for their migraine disease. It may be better to be on a consistent sleep schedule. When we talk about meals and hydration, you want to make sure that patients aren't doing long periods of fasting. So we typically say choosing 3 meals a day, trying to avoid skipping meals. Some patients don't like to eat 3 large meals a day, so maybe 5 snacks throughout the day might be useful for that individual patient. Hydration is another area of importance. So we try to avoid very sugary drinks. We try to avoid highly caffeinated drinks and high energy drinks. And you want to make sure that patients consume enough water. So we typically say about half their weight in water. Plus, we usually advise extra hydration for athletes. And again, giving them those numbers and those goals to shoot for is a lot more useful for patients than just saying drink more water. Because again, like I mentioned, if they're already drinking a little bit of water and they double that, it still may be far below what they really should be shooting for. And then again, they'll think that was an ineffective piece of advice and maybe abandon it. So if you give them those specifics and they actually know what they're working towards to do. The next piece that can be useful is activity. So the American Academy of Pediatrics actually recommends that children get an hour of physical activity every day. But when we start trying to get patients to move towards that goal, we recommend that you start with at least 30 minutes of activity 5 days a week and then try to increase that as tolerated. And once you look at adult studies for activity, it's a little bit higher threshold, probably an hour 5 days a week, where it starts to have migraine benefit. But of course, if you just told someone to exercise more, or gave them that initial that endpoint statistic of an hour 7 days a week, that might seem unattainable. So helping them create a specific goal that gradually increases to the level that you're trying to get them to might be more useful than just saying exercise more. Relaxation is another area that's important. So using techniques in the middle of an attack, counter pressure, for example, to help them have a counter source to the pain they're experiencing migraine, but also just overall awareness of managing stress and building in some mindfulness and some stress management into their day-to-day can be helpful for migraine disease over time. Certainly, if there are things like mood disorders, it's recommended that those are treated, and then cognitive behavioral therapy has some evidence in migraine disease as well. And then finally, the last part of the mnemonic, the T, is triggers. So you will have patients who have had migraine disease long enough that they have started to identify patterns that are very specific to them. And talking through those patterns with patients, helping them recognize if they don't know yet, giving them ways to try to track that. And then avoid their triggers or modify their triggers can be really useful. And again, that has to be very individualized. There are lots of people who report triggers that may not be something that's studied in the literature, but talking to them about how that can be helped or how they can work around that can be very useful for them when they're living with this disease for a very long time. So again, I think this is a tricky area. I think that's one of the most common things I hear in patients who come to headache clinic is that they were given this advice and they feel like they've tried it, but when you really start to break it down, they either left with an understanding that this was going to cure their headaches, and that's not the point of it. No one was saying that the cause of it was not drinking enough water. It was meant to help the disease state. So they come with disappointment that they did some of these habits and it didn't get rid of the headaches because that part was missing, the cause. Second, they feel like they've tried things, but they weren't reaching appropriate goals for it to really impact their disease state because they weren't given those appropriate goals, or they weren't talked to about how it takes time for these things to really impact their disease state, and they become frustrated when it doesn't work within a day or a few days of trying some of these healthy habits. So I think to have success, you really have to hone in on this and recognize how important it is in a multi-step treatment plan, in addition to something to do when you have an attack, and then possibly prevention if you need. But this is a piece that really just can't be skipped in pediatrics. It has to be done for our patients. So I think that's all that we have for today. Dr. Strauss and I thank you very much for joining us. We really enjoyed talking about this topic and hope it was useful for you today.